So to begin with, I would like to invite Dr. Tarjani Dave. She's already here with us. And over to you, Doctor. Thank you.
Thank you, Purnima, and good morning, everyone. So we are back again this year with our course on orbital diseases, real world cases, real lessons, true learning. The aim of this course is to familiarize you via case-based approach on certain conditions of the orbit, such as thyroid eye disease, orbital inflammations, or inflammatory diseases of the orbit, and orbital fractures. We have with us a stellar panel that you can see up there. Joining me today for this course are Akshay Nair, Samir Mahapatra, Saurabh Kamal, and Mohammad Shahid Alam. We have a couple of talks lined up for you. We'll be starting with Saurabh, who will take us through the medical part of thyroid eye disease and sort of give us certain insights into the management guidelines. Followed by Akshay, who's going to talk to us about idiopathic orbital inflammatory disease. I'll be talking to you about case scenarios in orbital decompression and customization that we do. Shahid is going to talk about orbital fractures and what implant suits your patient best in a particular case scenario. Samir is going to expand on it and talk about certain complex orbital fractures. And the last one would be a case-based discussion where we'll be asking all the panelists certain questions, and this will be related to firefighting over unexpected post-operative outcomes in your fracture cases. And then we have a little dedicated time slot for panel discussion with all the speakers. If we have any questions in the chat box, those will be answered at this point of time. We have 10 minutes for every talk, and I hope everybody is going to stick to the time. So over to you, Saurabh.
Is my screen visible?
Yes, sir.
Yeah. So good morning, everyone. My topic is thyroid eye disease, active, inactive, and confusing, and covering the newer insights into the management guidelines. Thyroid eye disease, as we all know, is the most common orbital disease in India and US and Europe. It constitutes about 1/3 of the orbital disorders in India. The pathophysiology is complex and has been completely understood. The recent understanding is the primary cell is the orbital fibroblast, which differentiates into the mature adipocytes or myofibroblast and leads to the soft tissue expansion and the clinical manifestation of thyroid eye disease. Now, this orbital fibroblast is activated by a number of autoantigens and autoantibodies, which leads to the formation of autoreactive T cells, cytokines, inflammatory markers, various growth factors. And this is here where the medical management part comes into the picture. So understanding of this pathophysiology is very important in basically helping these patients to get the therapy so that we can decrease the disease manifestations. Now come on to some cases. This 25-year-old male who actually has a complaint of left eye small since 5 years. But on a closer look, he has a right upper eyelid attraction, lower lid fat prolapse, and also there is proptosis of the right eye. So he was basically having the manifestations of thyroid eye disease in the right eye, asymmetric disease. And we should not confuse these patients with contralateral eye enophthalmos or ptosis. So patients of thyroid eye disease typically have fat-centric disease. This is the one phenotypic manifestations which basically has lid malpositions and sign. Out of them, the most common is the upper eyelid and lower eyelid retraction. These are seen in 90 to 98% of the patients. They have temporal flare, lid lag, which is basically the upper lid lagging in the down gaze, especially seen in the asymmetric disease, and the lag of ophthalmos, entropion, and the ptosis. Now, temporal flare is a classic presentation of thyroid eye disease, which is basically because of the strong lateral horn of the levator muscle, which pulls the muscle more temporally. That is why it is called temporal flare. Other manifestations are of the fat-centric disease are proptosis, the fat prolapse in the lower eyelid, retrobulbar discomfort, foreign body sensation, chemosis, superior limbic conjunctivitis, and lacrimal gland enlargement. There can be just a simple presentation like this, having no signs except the upper and the lower eyelid fat prolapse, and these are typically seen in young patients who are hypothyroid. Other phenotypic presentation is a muscle-centric disease, and these patients, they have myopathy, which is caused by the infiltration, swelling, and scarring of the cytokines, and leading to the diplopia, restriction of the movements, and there is a classic involvement of the first inferior medial rectus and then superior rectus. Now, these patients, they have minimal proptosis, more of an active disease, and these patients are mostly male and the older age group patients. Now, ptosis is, as I said, the upper lid retraction is the most common, but the ptosis can be seen in thyroid disease, and basically it happens in the active stage because of the edema or because of the compressive neuropathy and associated myasthenia and/or myasthenia. Other patients may have a mixed phenotypic presentation, such as the of both the fat-centric and the muscle disease, like this patient having a restrictive strabismus, proptosis, and eyelid signs. Now, the visual loss is around seen in around 4 to 8% of the patients, and it happens because of the dysthyroid optic neuropathy, which occurs in the patient with minimal proptosis. And this occurs because of the enlargement of the extraocular muscle, which causes compression at the apical. Other aspect is the visual loss caused due to the corneal exposure or melt, and this is classically seen in patients with severe proptosis and the lid retraction and lagophthalmos. Now, why we need to know the classification of this disease is because if you see both these patients, they look almost similar, but when we closely take the history and examine them, the one patient on the left hand side, she has a short duration. She's a known case of hyperthyroid, has the eyelid signs, and therefore is a case for medical management. Whereas the picture patient on the right side, she's a euthyroid, onset 4 years back, and she doesn't have any signs and symptoms except for proptosis and eyelid retraction, and she is a candidate for surgical management. So how do we decide that which patient needs medical and surgical management is important? And it is important to know about the Rundle's curve, which should be plotted in every patient, which is basically a natural course of the disease and which comprise of the two phases, the active inflammatory phase and the chronic fibrotic phase. Active inflammatory phase typically lasts for 1 to 1.5 years, but it is not a rule. It can be not completely seen in any patient, or it may be prolonged or may be shortened also. What is important to know, if we treat this patient in the active inflammatory disease at the start of the active inflammatory disease, that's where the medical treatment is most effective. And as the timeline progress, these patients, they convert into chronic fibrotic phase where the medical treatment is not effective. Another aspect is if we treat these patients medically in the start of the active inflammatory phase, it actually leads to the down phase of the active inflammatory phase, and also the decrease in the chronic fibrotic phase. So this leads to the ultimate reduction in the sequelae which the patient will have. But this is not simple, because the recurrence, even if the patient is on active inflammatory, is on the active medical management, the recurrence can be seen in 8 to 29% of the patients. And even in the chronic fibrotic phase, the reactivation of thyroid disease can occur in 5% of the cases, especially after the orbital decompression. So there have been various classifications. The first was by the Werner, the NOSPEX, but it has several disadvantages. The most commonly now which are utilized in the clinic are the Moritz classification or the UGOGO classification. UGOGO means European Group on Grave Orbitopathy. So these are basically similar, except that the Moritz has more 3 points which are added during the patients in the follow-up period. So this is a clinical activity score. It has 7 points in UGOGO and 10 points in the Moritz. For UGOGO, there are each 1 point for these 7 scores. So the one is for the orbital plane. The patient has a spontaneous orbital plane. 1 point for the gaze evoked orbital plane. 1 point for the eyelid swelling, erythema, conjunctival redness, chemosis, and one is for the inflammation of the caruncle. So we calculate and add up these all points, and more or than equal to 4 suggests the patient has an active disease. So let's look at this calculation of these points for this patient. She has a pain at rest, on movement. There is an eyelid edema, erythema, conjunctival injection, chemosis, and caruncle edema. So she has 7 out of 7 points. On this patient, if you see the right eye, he has 5 out of the 7 points. And this is an example of an asymmetric disease, or the clinical activity score. The patient having 3 points on the right side and 4 points on the left side. So we treat this patient especially in the asymmetric disease, we take the clinical activity score on the higher side. The UGOGO has also classified the thyroid disease into the severity. So I talked about the activity, which is basically the timeline of the disease, and it decides whether the patient will be benefited from the corticosteroid therapy, especially if the score is more than equal to 4. Another aspect is the severity of the disease, which is, as can be seen, is involvement of the various eyelid structure, proptosis, and the exophthalmos. Another aspect is the visa classification, which has a 20 points. It has a 10 inflammatory scores, and these are basically expanded of the, we have a 2 points for the eyelid swelling and 2 points for the chemosis. So for visa, the inflammatory score more than equal to 5 is important. There is a role of investigation. Obviously, the thyroid disease does not correspond with the thyroid dysfunction, and we should have these patients underwent thyroid function tests, the antibodies for the Graves disease and the Hashimoto thyroid disease. CT scan is helpful to know the cases in asymmetric or atypical pattern. It is not useful for diagnosis otherwise, and also before the surgical plan. So this patient is having predominantly a fat-centric disease. You can see the extraocular muscles are normal. I'll just be finishing, and the MRI is not that useful, although it picks up the soft tissue signs. The another thing is the CT can help in the calculation of Barrett's index, which indicates that more than 67% is predictive of the dysthyroid optic neuropathy. So it's important to know the risk factors, especially the modifiable risk factors, which are radioactive iodine, cigarette smoking, and thyroid dysfunction. Dysthyroid optic neuropathy is seen in 4 to 8% of the cases, and as I mentioned, it is typically seen in patients with muscle-centric disease who have minimal proptosis and significant strabismus. So how do we manage? We first assess the disease based on the activity and severity, and then classify them as active or non-active, and on the severity as a mild to moderate, moderate to severe, and then dysthyroid optic neuropathy.
I'm extremely sorry.
I'll just take.
I have to interrupt. I'm extremely sorry about this, but
yeah, he's just finishing.
Yeah, can
okay.
Yeah, I'll just sum up. I'll just sum up.
Thank you.
So for the mild, we provide the symptomatic treatment, and for the moderate to severe, we start the patients on either on the oral or the IV corticosteroids. So IV methylprednisolone is indicated in patients with active disease at less side effects, but the total dose is the 8 grams that we have to remember. Other treatment aspect is the immunosuppressives and the biologics, and this is how we treat the patients now, and it should be treated before the start of the disease itself. These are the biologic agents, infliximab, etanercept, and rituximab, which can be used, and the recently added one is a teprotumab. Radiotherapy is a limited role, especially in patients who are not responding to corticosteroids in moderate to severe disease. And this has been shown to decrease the strabismus, long-term motility disturbances in these patients. So to conclude, the thyroid disease had varied clinical presentations and signs. First, you should establish the diagnosis, typical the subtle symptoms and signs. Obviously, the patients having a proptosis and lid retraction, they are easy to pick up, but the challenge is diagnosing the patients which the minimal symptoms and signs. It is a multidisciplinary team. It requires approach, and the management is based on whether the patient has active, inactive disease, what is the severity and the duration on the Rundle's curve. Thank you. Sorry, I exceeded the time limit.
Thank you, Saurabh. While I think Akshay has yet not joined us, so maybe we'll move ahead with the part on customized orbital decompression in thyroid eye disease, because we've already gone ahead with thyroid. So hello, everyone. I'm Tarjini Dave, and taking the management further from what Saurabh has shared, I'm going to talk to you about customized orbital decompression. I hope my slides are visible and I'm clearly audible.
Yes.
Yes, absolutely.
All right. So I have no financial disclosures to make. You'll be seeing certain full face photographs of my patients for which we have the consent. The objectives of my presentation today are to talk to you about the walls of decompression, basically to understand why we do what we do, the indications for orbital decompression, specific situations like bilateral extreme proptosis, unilateral extreme proptosis, unilateral extreme with myogenic presentation, cosmetically disfiguring proptosis. How do we go ahead with one-stage management in certain cases that require orbital decompression, a little bit on dysthyroid optic neuropathy and congestive orbitopathy. And I'm going to do this with the help of 10 case scenarios. So briefly talking about the walls of orbital decompression. So what are the walls that we address? So it's fat, lateral wall, medial wall, and floor. These are the 4 walls of orbital decompression. And you can see examples of 1 and 2 wall decompression pre and post-op as you're seeing here. And 3 and 4 wall decompressions, obviously with more grades of proptosis requiring more amount of decompression in the orbit. So essentially your management paradigm would be when you have minimal proptosis and it is a fat-centric disease, or even in certain cases of muscle-centric disease where you have minimal proptosis and dysthyroid optic neuropathy is not a concern, go ahead with fat decompression. When you want to add more effect of decompression and produce more enophthalmos, this is the sequence that you follow. That is the lateral wall, then the medial wall, and finally the floor. So this is the paradigm that is followed in most cases. And why do I say that? Essentially, there's a concept known as balanced versus unbalanced orbital decompression. So what is balanced? When you remove a part of the lateral wall and you also remove a part of the medial wall, you're widening the orbit so that the globe falls back into position. This is balanced because you have done it on 2 opposing forces. Versus that, what is unbalanced? If you do floor and medial wall, then it is an unbalanced decompression because your globe can sink inferomedially. So new onset diplopia is one of the biggest concerns following decompression. And this is as high as 30%. And it's higher in patients that have an unbalanced decompression versus a balanced decompression. This is just a graphic to show you what happens in a balanced decompression when medial wall and lateral wall both are tackled. You have the globe falling back in its position as you see along the yellow lines. Versus that, if you have an unbalanced decompression, the globes will be falling inferomedially, and this tends to produce more amount of diplopia. So if you look at what are the traditional indications for orbital decompression, this is in most situations performed when the patient is in the inactive phase of thyroid eye disease, has extreme proptosis, which can be cosmetically disfiguring, or in certain cases of active thyroid eye disease where you have compressive optic neuropathy, and a small subset that has congestive orbitopathy that I'll talk to once we reach that part later on. These are just certain case examples to show you the different situations in which you can perform orbital decompression. So let's talk about bilateral extreme proptosis. So this case 1, where you have a 39-year-old male. He complains of proptosis of both the eyes. He's had this since 3 years. There's been no progression in the disease in the last 1 to 2 years. And you label him typically to have inactive thyroid eye disease based on the signs and symptoms that Saurabh just mentioned. And he has extreme proptosis. Look at his hurdles, is around 29 and 30. And if you look at his scans, then both his eyeballs are practically outside the line that's joining your anterior part of the zygoma, which is labeled as extreme proptosis. Look at his coronals and you realize that it's mostly fat-centric disease. There's a little bit of muscle enlargement, not too much. So these are a delight to operate because you have a lot of fat that can be debulked. Muscle is not coming in your way. It's bilateral. You're not worried about producing too much of diplopia. So in these situations, with your classic 4-wall decompression, which includes maximizing on your lateral wall, then decompressing the medial wall, removing a little bit of the floor, and also addressing the fat from the areas of the orbit where fat is predominant. And this is the outcome that we achieved in this patient. This sort of bilateral decompression can either be done bilaterally simultaneously, but it becomes really backbreaking. And at times you can break it up into one eye at a time. Typically, hidden incisions such as the eyelid crease, inferior transconjunctival and transcaruncular are used. So you see this patient having undergone first the left eye and then the right eye orbital decompression. This is after the left eye and this is after the right eye. And this is the final picture where you can see pre and post-operative bird's view showing there is a significant reduction in the amount of proptosis. Now, when you have a situation of extreme proptosis, you are in a good position if your orbits are deep, if the disease is bilateral, and it is also adipogenic. But if you see any of those red font things, it should alert you and it should raise a flag because treatment is going to become extremely difficult surgically. So what do I say? What do I mean when I say deep orbits? Now, these are two lines passing through the top and the bottom of the lateral wall. And if you can look at it, you can see that the shallowness of the orbit is seen in the picture on your extreme right-hand side. Such cases are extremely difficult to treat and it becomes difficult for you to produce significant enophthalmos. So this is one parameter you want to look for on your scans preoperatively before you plan your treatment strategy. Looking at the other difficulties, now this is a case example of a 47-year-old male who has unilateral proptosis. You see the left eye out there. It's a stable disease now. We've established that he's in the inactive phase and he has a Hurdle's difference of about 9 to 10 millimeters. If you look at his scans, he has a little bit of muscle enlargement also here, but there's a good enough amount of fat that you have for him. In such situations, it becomes very important to perform what is known as balanced orbital decompression. If in this situation you go ahead and you remove the floor only on one side, you have a high chance of producing inferomedial migration of the globe and producing new onset diplopia. So in such situations, you go maximally on your lateral wall. You also remove the medial wall. You preserve the floor, but you remove what is known as the posteromedial strut from where the fat can prolapse into the sinuses and give you a little effect of decompression. The worst is this sort of a situation where you have unilateral disease, it's myogenic, and this is a real terror to treat. So again, a patient who's in the inactive phase, and again, a 10 millimeter proptosis over here with muscles which are really nice, fat, bulky. This becomes extremely difficult. And when you are in this sort of a situation, you want to maximize on your lateral wall. And what do I mean by that? There are three areas of your lateral wall. The lacrimal keyhole where you begin your drilling, the sphenoid door jamb or the extreme posterior part where you actually want to remove the entire cortical and medullary bone and expose the middle cranial fossa dura so that you have maximum reduction in the proptosis as you see in the postoperative scans over here. And finally, you approach the basin of the inferior orbital fissure. You know that the geometric shape of the orbit is such that expanding the basin gives you some more recess for the fat to flow into the pterygopalatine fossa and give you maximum effect of decompression. So this is this gentleman who had unilateral extreme disease, myogenic variant, pre and post-operative photographs, a challenge to treat, but if you follow the algorithm, you're surely going to get good enough results. Now, another situation is something like this, where you have minimal proptosis, not too much of a difference, 3 millimeters of relative proptosis, but you have an inferior scleral show as well, which is bothersome for these patients. And in these typical situations, what I tend to do is I drill more towards the basin of the inferior orbital fissure and create some space there for the eye to move slightly inferiorly, while you're also addressing the lower eyelid retractors to bring the eyelid up and hence sort of tend to remove or take care of that inferior scleral show as you see in the post-operative example over here. one little word on one stage management. So patients like these who are worried about the upper eyelid blepharochalatic or dermatochalatic appearance, along with little bit of maybe about 2 or 3 millimeters of bilateral proptosis and mainly adipogenic disease, it's a good idea to go ahead and remove your fat, intraconal fat, as you see in the area in the blue over here. Just the fat decompression gives you a good reduction in the proptosis, and in the same sitting you can actually address the upper eyelids also and give a nice crease to the upper eyelid so that the patient looks much more symmetric. A little word on those with active disease. So this is a patient with dysthyroid optic neuropathy, and you've gone all guns blazing, completed your entire immunosuppression that you could have given this patient, and despite that the patient keeps worsening with the vision dropping again and again. So what do you do in this situation? This is again a classic example where you can go ahead with compression. I'll be wrapping up in a minute. And if you see over here, in these situations, you do an unbalanced decompression involving the medial wall and the floor, because those are the muscles which are closest to the optic nerve, and you want to push them away so that the optic nerve gets a breather and is able to gain vision again. A short word on congestive orbitopathy. So this is a patient who looks active. We treated with steroids, but even following treatment with steroids, continued to have a little bit of activity. Now, if you have this tense proptosis, then the venous return is impeded. Blood is coming into the orbit but is not able to go out. And in those situations, you have congestion in the orbit, which might simulate an active presentation. And again, these are patients who are candidates for early orbital decompression. So in summary, I've spoken to you about the walls of decompression, how we go about with the treatment algorithm, a specific note on the unilateral extreme myogenic variant, one-stage management, dysthyroid optic neuropathy and what you do in those situations, as well as congestive orbitopathy. Thank you so much for your attention. We'll move on to the next talk. Akshay is here and we can go ahead with his talk on idiopathic orbital inflammatory disease. Over to you, Akshay.
Thank you, Tarjini. I'll just share my screen. Yeah, my screen is visible, right? Great. So
Yes.
I'll be talking about orbital inflammatory disease. So first thing is that we need to understand what is orbital inflammatory disease. It is an open-ended non-diagnosis where a definite cause for the inflammation is not known. It is not a unfortunately, what is happening is that it is being treated as a waste basket bin, where everything and anything that doesn't make sense clinically is being designated as orbital inflammatory disease. So IOID is idiopathic orbital inflammatory disease. NSOID is non-specific orbital inflammatory disease, both equally non-specific and idiopathic names. And I'll try to explain why. So first thing is that inflammatory disease is a tissue response. It's not a disease. Also, response to steroids is not a diagnostic criteria. And there are many conditions that present as inflammation and that respond to steroid, including some amount of response is seen in bacterial cellulitis. That doesn't mean that is orbital inflammatory disease. So in cases that present with what is called typical orbital inflammatory disease, a systemic cause or an association must be investigated. And when we say must be investigated, it's ideal that it be thoroughly investigated with a rheumatologist on board and find a cause, because when you know that it is in association with an autoimmune condition, then it is you have a clear nature or a clear association. Only when you don't find a cause, you can then call it an non-specific orbital inflammatory disease or idiopathic orbital disease. Now, what does this include? This orbital inflammatory disease can affect any of these structures that we see: the lacrimal gland, the extraocular muscles, the optic nerve sheath, the fat within the orbital apical structures, or even the periscleral tissue around the globe. And these are not mutually exclusive. You can have overlapping structures being associated and therefore a complex presentation. So typically, how does it present? I'll cover 3 clinical scenarios that we commonly see. Lacrimal gland association. This can be unilateral or bilateral, but more classically unilateral and sequential. Pain is typically seen, although rarely it can be painless. the course is acute to subacute, and classically you see an S-shaped eyelid that you see here. Again, subjectively, in terms of complaints, you have patients, like I mentioned, across the spectrum. Patients who are absolutely painless, in which case it more likely could be a viral dicryoadenitis, or in patients where there is, there can be severe pain as well. Myositis typically is unilateral, presents with pain and associated, motility and functional restriction of the muscle, which leads to diplopia, congestion, and chemosis. This is how typically the patient would present. You can see in the CT scan, there is a lot of preseptal edema and inflammation, along with thickening of the extraocular muscles and the lacrimal gland here as well. So it's not always mutually exclusive, like I mentioned earlier. The horizontal recti are typically more affected. There is always usually normal bone, and spillover inflammation into adjoining structures can be commonly seen. Differentials for this can be thyroid eye disease. As you can see, this mimics a lot of active congestive thyroid eye disease that Dr. Tarjani showed. Orbital cellulitis or metastatic lesions in the orbit. Diffuse orbital inflammation. It can be unilateral. It usually is unilateral, and patients will have a history of repeated episodes on and off. There is severe proptosis, ophthalmoplegia. If there is associated perineuritis, there is a significant visual reduction. And here again, your differentials can be thyroid eye disease, bacterial cellulitis, and because there is so much congestive inflammation seen, a CCF can also be suspected, and you need to rule these three things out as well. So what do you need to do as an investigation? So here, radiology is important. Radiology can, typically be, I would prefer now an MRI or even a CT scan can give you a good guide, because you are able to visualize structures like the lacrimal gland, the extraocular muscles, and the optic nerve, even on CT scan. So on MRI, what do you see here? You can see isolated inflammation of the lacrimal gland, which is enhancing with contrast on the right. Again, you can see the extraocular muscles, they appear thickened in size and enhancing with contrast. Here, especially the superior rectus, which is appearing so hyperintense because of the contrast uptake. Diffuse intraconal disease can be seen very well. And here again, you are seeing intraconal fat standing along with thickening of the extraocular muscles, which is very, very typical of this condition. Perineuritis with contrast enhancement, you see a ring around the optic nerve. Also, you can see a dilated SOV along with thickening of the extraocular muscles. Here you are also able to see the episcleritis as a form of manifestation of orbital inflammatory disease. If your MRI doesn't reveal anything, then you should, and if the radiologist suspects, an angiogram can also be done to rule out CCF. On CT scans, findings are a little non-specific because it can be hyperdense, iso to hyperdense, irregular intraconal, extraconal lesions where your anatomy may not be that clearly visible. This is a patient I'll come to later on, but you can see the amount of thickening of the lateral rectus and inflammation along the lateral wall of the orbit. This again is a same patient who had a CT and an MRI, and you can see that the clear delineation of the inflammation in the sclera along with the retinal detachment and the perineuritis or optic neuritis is very clearly visible. So how do you investigate, and when to investigate, and what do you do? Your classic investigations would be hemogram, CRP, your thyroid profile, and you need to make sure triple H is done to make sure that the patient is not immunocompromised, and infectious focus, including tuberculosis, is ruled out before you can start treating them with immunosuppressants. Your basic panel of serology is ANA, ANCA, HLA-B27, serum angiotensin converting enzyme to rule out sarcoidosis, and serum IgG4 levels. These are what the laundry list of tests that usually are done. Now, if it is mild disease, your diagnosis can be clinical, and you may give a trial of non-steroidal anti-inflammatory drugs. If it is classical disease like the three patterns that I mentioned, where patient may have pain, there is diplopia, typically for the horizontal recti, and proptosis, then is when you do your basic lab testing that I mentioned earlier, investigate the patient, and start on oral corticosteroids with a controlled taper. consider steroid sparing agents only if their patient is not intolerant to steroids. And if it is atypical disease that doesn't fit in the pictures that we discussed, where the pain can be severe to even debilitating, but there may be very little diplopia, or active inflammation may be absent, but the patient has signs of proptosis, etc. In these cases, you may want to consider an incisional biopsy as well. Also, an incisional biopsy can be considered at any presentation, because in the end, if you have a tissue diagnosis, it is always good. How do you manage? Do you always give a trial of steroids? No, because a response to steroid is not confirmatory of of idiopathic orbital inflammatory disease. Do you biopsy all patients, or do you see only typical or atypical cases? So literature tells that the classic presentation is abrupt onset, pain, periorbital edema, erythema, chemosis, and even diplopia, proptosis, and vision loss. This is typically what we see, and therefore this algorithm will help you. Once you image, once you've done your investigations, and then you can give a short course of systemic corticosteroids. And if you get a good, rapid, sustained response, you taper it off, and that would be the end of it. However, if they don't tolerate, you should then consider intraorbital steroids, which have a short duration of action, and possibly a biopsy. But if there is poor response, then you should definitely consider a biopsy, because then you're working with something else. And this is where your rheumatologist comes in. So in your atypical NSOID, where it doesn't fit the classical symptoms as well as imaging findings, your threshold for biopsy has to be very low. And treatment of this is always in conjunction with a rheumatologist. Sometimes you may have to think out of the box for treatment options. This is a patient who came with repeated episodes of orbital inflammation. You can see the amount of proptosis, chemosis, the extraocular muscle thickening. She had a history of a lateral orbitotomy earlier. You can see from the lateral orbital rim, there is some bony changes there. And a repeat biopsy was done. It was sclerosing non-specific orbital inflammatory disease, or IOID. You can see that in the image above, which is at presentation, and the image below after a course of IVMP, that the response was good. But again, she would come back periodically with worsened disease. Again, these are pictures over different stages where she would go back into improvement and come back again with worsening disease. And finally, she was put on azathioprine. However, this was a young patient who wanted to get married and conceive and have a child. So we had to take a call on stopping disease. We went ahead with low dose radiation to the orbit, and that worked wonders for us. This is on the left, you see the stages of multiple, disease quiescence and activity that she came. And this is a final follow-up after receiving EBRT to the orbit. So sometimes, we may have to think of different things. To summarize, a trial of steroids is not completely wrong, but do not undertreat it. Whenever you suspect things, anything atypical, biopsy it so that you can able to rule out conditions that can mimic it, like lymphoma. IgG4 is something that you should always add, because IgG4 disease has systemic implications. Patients with IgG4 related disease have a higher chance of systemic lymphoma. The biopsy is also required because you need to know what you are dealing with, whether it's a sclerosing variant or not. Sclerosing variants typically don't respond well to therapy. I'm finishing up in 30 seconds. This was a paper that we had published where we did IgG4 staining on all cases of idiopathic orbital inflammatory disease retrospectively. And we found that almost a third of all patients who were treated, who were labeled as regular non-specific orbital inflammatory disease, were actually IgG4 positive disease, which, like I mentioned, has systemic implications as well.
Thank you, Akshay. So we've had a fantastic coverage on all sorts of inflammatory diseases to the orbit of the orbit, and we move on to fractures now. I'd like Shahid to share his screen and take us through the G-force in orbital fractures. What is it? What implant suits your patient the best? Shahid, can you start sharing your screen, please?
Yeah, just a moment, Rajini. Is it visible?
It's just started. It says your, yeah. Go to full screen, please, Shahid.
Yeah. Yeah.
Go ahead.
So, good morning, everyone. So, without taking much time, I'll just move into my presentation. So, we have come a long way as far as orbital fractures management and the pathophysiology is concerned. It was first described by Mackenzie in 1844, and from there on, blowout fractures and then muscle entrapments were described, and then iliac bone for calvarial reconstruction came up, and finally, in early 1990s, we came up with the use of titaniums for orbital fracture management. So what are the key factors for management of orbital fractures? There's timing for surgery, the surgical competence of the surgeon, and of course the choice of implant, on which I'll be talking about. So the perfect match that we when we look for our life partner in our life, these are the factors that we look for, which is like they should be compatible, non-irritating, flexible, they should be supportive, they should be available when we need them. Of course, some of us are worried about the figure and contours, and of course the wallet size also matters for some of us. So when we extrapolate these factors to our orbital implant, so they should be biocompatible, they should be non-allergic, they should be flexible and support the orbital contents very nicely, and the material should be available in sufficient quantity. They should be easy to contour upon, and yeah, they should be cost effective also. So we have a lot of options, and there's a lot of batteries of implants that we have come across, but only few of them are routinely used. The most common one, which still considered the bone, the gold standard, is the autologous implant, the bone. Allogenic and xenograft material are much of academic significance. Then alloplastic metals in the form of titanium is very commonly used nowadays. Polymers, silicon were very common in the past, but because of its complications, we have given away with silicon. Polyethylene, is used in many cases. And then nowadays a lot of talk about the composite implants. So what are the factors influencing choice? The defect size, the number of walls involved, how well the implant can adapt to the internal contour, whether we are talking about volume restoration or just about talking about functional impairment in the form of diplopia, and whether the repair is early or late. So we're just taking with some cases. So this is a patient who presented with diplopia after orbital fracture. As you can see in the picture, here you can see the patient is not able to elevate his left eyeball, and this is the CT scan picture. As you can see here in the left orbit is a trap door fracture. This is a classical teardrop sign, as we call it. So the muscle has the bone has fractured, and it has come back to its original place because of the pliability in young patients, and the muscle has just entrapped there. So these cases, they don't need much of a volume restoration. We just need to go and release the muscle, and that was what it was done here. So, and this is the post-operative imaging. So what sort of implant we have put here? It's an osteomesh, which is a polycaprolactone, and it's an absorbable material. Since we are not concerned about much of the volume restoration, so once the implant has done its job, even if it gets absorbed, it's not much of a concern. Now this is another case. No, this is a post-operative result. You can see here, here the elevation, which was limited in the previous picture. Now it has nicely been restored. Now another case, 13-year-old boy complains of double vision post accidental fall, and here you can see depression is limited in the left eye. So, and this is the imaging. So here also you see this is the most common site where the orbital fracture takes place, the infromedial wall. So here there is a fracture in the infromedial portion, and the contents have herniated into the sinuses. So here also a fracture repair was done, and as you can see, this is a post fracture repair. The depression, which was limited earlier, it has nicely been restored, and this is the post operative imaging after the implant replacement, and this is the implant that we have placed here. So you can see it's nicely going up to the orbital the palatine portion of the orbital bone, and here the defect has nicely been covered. So this is the 3D recon picture of the same patient, and you can see the pre-contour titanium implant has nicely been placed covering the floor and the inferomedial portion of the orbit. Now another case here. So post-trauma, of course, and gross in ophthalmos of the right eye, and you can see large fracture of the on the right side. Almost the floor is absent on the right side, and whole of the content is herniated into the orbit. So in these cases, and it was a late case presented to us almost after 3 months. So in late cases, rather than placing an implant, releasing the contents and restoring them back into the orbit is quite a challenge, because there is a lot of fibrosis, and on top of it we have a lot of vessels going into it, and there is a lot of bleeding when we try to remove those fibrotic materials and put it back into the orbit. So here we are much concerned about volume restoration. And this is the recon picture of the same patient, and this is a post-operative picture. You can compare it how nicely the in-ophthalmos has resolved. So in this case, we have put a titanium implant, and over that we have put a mid-pore to augment the volume. So in some cases, you can also combine titanium with mid-pore or bone with a titanium implant, as I will show in my next picture. Now here, this patient. So here, this is a post-operative picture of a patient. Right-sided orbital fracture repair has been done, and there is not much of in-ophthalmos, but the patient is worried, like how did such a big implant go into the orbit. So we routinely do this post-operative imaging. So here in this patient, we were able to convince him with this post-operative imaging that, see here, this is the implant which we have put into your orbit. And the point which I want to emphasize here, that with the conjunctival incisions, the scar is hardly visible. You can't see any scar, and it's very cosmetically acceptable as compared to the lower lid subciliary incision, which gives a bad scar and also in some cases results in ectropion. Now this is another case. Again, large fracture on the right side is gross in-ophthalmos, and volume restoration is a concern here. So in this case, what we have done, as you can see in this picture, this is a post-operative imaging picture. This is a bone graft which has been fixed with screws, and over that we have put a titanium implant, and the volume has nicely been restored. So as I told, you can combine implants also in some of the cases. So it's a bone graft with titanium mesh. This is another case. Again, a green stick fracture of the floor of the medial wall of the right orbit. Here you can see there is a fracture. The medial rectus has gone into the ethmoid sinus. The fracture element have come back, and the muscle has just snapped back there. So what we need to do here, we just need to we need to release this muscle, and we don't need much of a volume augmentation here. So in this case, what we have done, we have put a X-ray film in this case. X-ray film which was autoclaved and sterilized, and then it has been placed into the orbit. And this is the post-operative picture. You can see here the adduction which was limited, it has restored. So what are the surgeon's view of an implant? It should cover the entire defect, and it should conform nicely to the walls of the orbit, and as much as possible it should match the uninjured volume of uninjured orbit in volume. And it should not migrate, it should not cause hypertrophy of the globe, and it should not necessitate removal or debulking as is required in some cases of bone implants. So this is a paper by Potter et al. And as you can see nicely here, that porous polyethylene and metallic mesh, they score quite good on most of the criteria as compared to the autologous bone implant. So the perfect match which we talked about might not be practical in our routine life. And just to conclude, the search for an ideal implant still goes on, and it's a topic of an academic discussion. Is autologous bone the gold standard still? The time will tell. And resorbable materials might be the future. And a word of caution with alloplastic implants like titanium is they can result in orbital adherence syndrome in some of the cases. Thank you.
Thank you so much, Shahid. So after this fantastic coverage by Shahid on the types of implants that can be used, we move on to Saurabh, who's going to talk to us about managing complex orbital fractures in a case-based way. Samir, I meant. So Samir, over to you. Thank you, Samir.
Yeah.
My slides are visible?
Yes, Samir, just go to full screen. They are visible.
Yeah.
You're audible as well. Go ahead, Samir.
Yeah. Thank you, Tarjani. Good morning, everybody, for this session. And we will, I'll take forward what Sahid had already discussed. My focus will be on complex orbital fractures and what did I learn and what we can learn from such cases in managing complex orbital fractures. Now, complex orbital fractures always are associated with mid-phase trauma. Mid-phase is considered to be the crumple zone, which are vulnerable to injury, causing multi-fragmentary fractures. These are often vision-threatening and always require a coordinated multi-speciality care for the optimal outcome. Now, what challenges do we face as ophthalmologists because of the severity of the trauma, because of the lack of expertise and the skill and the resources? Patients do often present to us very late after multiple procedures have been done, and for it we always require a dedicated orbitomaxillofacial team, which often is lacks in most of our practices. So the key points what needs to be understood is to maintain the facial anatomy or the structural anatomy of the face, which consists of 4 transverse and 4 paired vertical buttresses. And the goal of any reconstruction of this mid-face fractures is to maintain this occlusal relationship of the buttresses and to maintain the spatial relationship of this skull base with that of the maxillomandibular unit. Once this occlusal relationship is maintained, then all of the fractures will come into place. It's exactly like a building where you put up pillars and then slowly the walls and the decors come in. So first, the structural anatomy of the buttresses has to be maintained, and once this is done, the entire fractures will come into place and we can have a better symmetry and cosmesis. Now with this, I'll discuss a few case scenarios which I had come across in my practice. Now this was the first case which invoked the interest of managing such complex orbital trauma in my practice. This was a 5-year-old female child who had sustained an unprovoked dog bite while she was playing. She was referred to us after the primary vaccination and anti-rabies care has been done. So on examination in the emergency, we found the left glove was completely subluxated with a tooth bite mark on medially. There was a deep laceration of the midface and it was bone deep. So the left eye glove was intact. So in the first attempt, we did a primary repair of the wound after thorough cleaning of the wound. The syringing was attempted on the and it was found to be patent. We enucleated the left eyeball. And following this repair, so what resulted was in a saddle deformity of the nose here, a white telecanthus, and a very, very cosmetically disfiguring face. So the imaging showed multiple comminuted fractures of the NOE junction, and this resulting with the saddle deformity and the telecanthus. So our plan was to bring back into anatomical orientation of all the small fracture fragments and then fix it to the stable bone with the help of plates and screws so that we achieve a near normal anatomical orientation. And this is what we did on table. You can see this was a large fracture fragment which was all mobilized after minimal osteotomies were done, and then slowly all these fracture fragments were put back into their near normal anatomical position and was fixed with plates and screws. Beside this, after even doing the anatomical reduction, we found the floor of the nose, or sorry, the bridge of the nose was not forming at all. And for a small child, we are not sure whether a bone can be harvested without any prior planning. So we just put a porous polyethylene sheet off to the bridge of the nose and was fixed to the stable bone here with the help of screws. And this was what the result after a period of 3 months. So you can see the bridge of the nose, though not great, has the saddle deformity has improved a lot with the telecanthus being corrected. So even we did a medial canthal fixation, tendon fixation to the fracture segment. Now we come to the second case. This was a 21-year-old female engineering student who sustained a blunt trauma with stone while she was traveling on train. So presented to us 2 months later with the complaints of decreased vision in the left eye and ptosis, which caused a cosmetic concern for the patient. On examination, the patient had a retinal detachment in the left eye with 5 millimeter inophthalmos in the left eye. However, the globe in the right side was intact with a good vision. So this was what the photographs in. This was the primary injury, which was repaired uh, at the first visit, and then the patient had come to us with the ptosis. Now, considering on the scan, it showed multiple comminuted fracture of the orbital rim as well as the flow. There was a fracture of the zygoma, and you can see in the 3D reconstruction images, this was all comminuted. The entire fracture fragments were comminuted. And you can see there was a large fracture of the floor, which was causing this sort of 5 millimeter of inophthalmos. So our plan was to repair all the fracture fragments and to reconstruct the face. So we took a hemicoronal approach to avoid any scar on the face of this female patient. So we can see the zygoma was completely comminuted here. So we have to osteotomize all the components, lift up all the components and do a stable internal fixation. And then following which we can see the entire orbital rim was shattered into pieces. So all this bone fragment, as this corresponds to the scan over here, all these small bone fragments were removed. And finally, a bone graft was harvested from the iliac crest. And then the entire rim was reconstructed with the help of this piece of bone. And the entire flow was reconstructed with the cortical sheet of bone. And this gave what was the result after 3 months. The hurtles has improved to about just 1 millimeter of inophthalmos on the left eye. The ptosis has improved. We didn't do any surgery for the ptosis. And though there was a lateral amount, small amount of ectropion laterally, but that was quite acceptable to the patient without any visible or notable inophthalmos or diplopia. Now come to case number 3. It was a different case. A patient was a 22-year male who sustained a road traffic accident. He was not wearing a helmet. So the only complaint he had was this subconjunctival hemorrhage temporally or laterally, and he was unable to open his mouth. He was a regular tobacco chewer, so he was unable to open his mouth, and that was his only complaint. On examination, the both eye had very good visual acuity of 20/20. There was no inophthalmos at all. The extraocular movements were full. The only thing what we noticed was a subconjunctival hemorrhage here, and if you notice carefully, the malar flattening, what we noticed on the right side as compared to that of the left side. So when we did a scan, there was a fracture of the zygoma. It was a very clean, undisplaced fracture of the zygoma. And on attempted repair, we just took a hemicoronal flap again to avoid any scar. You can see the fracture zygoma and the component has completely coved into the inside. Because of this, the fracture fragment was osteotomized, it was lifted up, and it was fixed with screws. And this was what was the outcome. We can see the malar flattening has improved a lot with very good cosmetic outcome. This was the last case which I want to discuss. The child was a 9-year-old child who had an injury with cycle handle 1 month back. He was treated initially by a neurologist and was referred to us after a period of about 20 days for evisceration because of the extensive exposure keratopathy what the patient had. The right eye vision is 20/20. The left eye vision was PL positive. PL was doubtful with PR inaccurate. Now, this was a scan, so you can see there was a bony defect on the skull over here, the one bony defect of the roof, and there was a bone fragment that was lying in the orbit, and there was a collection of fluid in the superior orbit that was pushing the globe out, causing exposure keratopathy. And this was what the MRI scan shows. There was a discontinuity in the roof, and the meninges appeared to have plugged into the defect and was quite adherent to the orbital tissues. So this was the craniotomy that was done by the neurosurgeon prior to presentation to us, and they have attempted a fracture repair, but the results were not good. Now, this is what we assessed, and we thought of just removing the bone from the orbit and just to preserve the globe of the patient. This was how we opened for the coronal section, complete scalp was opened up. So this was the prior orbitotomy or the craniotomy site that was present. So this appeared to be quite inadequate as per the neurosurgeon's discussion with the neurosurgeon. So another craniotomy was done to enlarge the craniotomy site, following which an endoscopic third ventriculostomy was done along, and then an external ventricular drainage device was fit into just to decompress the brain. So after the brain was decompressed, we can see this is the brain tissue, the dura was exposed, and we can see there was a large fracture defect over the skull. So the entire dura was adherent to the orbital tissue. So it was slowly, meticulously dissected out of it. And this was the defect that we see here. And following which an implant, a titanium mesh was placed over the defect, and over in that multi-layer dural closure was done. And finally, the craniotomy wounds were closed. And from the orbit side, I opened up the orbit, and as you can see, there was a large bone fragment corresponding to the scan here. And when we removed the bone here, this was the eye immediately after the surgery. At least it was, the photograph was taken 3 days after the surgery. This was the injury that was done because of the excessive use of cautery while doing the craniotomy. And this was the outcome at the end of 3 months. From the vision of PL inaccurate, the patient has now a vision of 20/200 in the right eye. The eyeball you can see, but it has become a little bit asotropic, but the vision is good. The B scan showed attached retina, and we plan to do a therapeutic keratoplasty in this patient. Now, I'll just skip over these cases. So these are some cases where even after my best attempt, I could not give good result. And yeah, I'm just finishing up. I'm just done. And this is one such case. Even after giving a best result, we didn't get a very good cosmetic outcome. So the major highlights are, for this sort of cases, a multidisciplinary team effort is a must. A prior discussion of all the possible procedures is important. Looking beyond ophthalmology is something we need to practice. It's not about ptosis, not about proptosis. You have to look into certain things which, like a meningocele, like a ptosis or inophthalmos leading to ptosis, need to be considered. Appropriate referral for somebody who is not used to this sort of case, managing these cases is important. And as I already discussed, maintain occlusal relationship of the facial skeleton, and to maintain the spatial orientation of the skull base with the maxillomandibular unit is important. Thank you.
Thank you, Samir. That was a fantastic presentation. So many complex cases which you highlighted well. So I'd request all the speakers to turn on their cameras and come on board for the rapid fire session. Purnima, the rapid fire and the panel discussion are together. This is the last one in our session, so we'll finish on time. Shahid and Saurabh, if you could please come on board. My slides are visible, right?
Yes, absolutely.
All right. So we are, this session is going to bring out certain cases that did not do well and question our treatment dogma and try and understand what went wrong with the help of the excellent panel that we have today. All of this is related to orbital fractures. Just wanted to invite everyone to one of our meetings at the Vizag campus called Looking Beyond the Eye, where we'll have a major session on mucormycosis as well. So this is essentially just our perspective, and it may not be a treatment paradigm, but what we are trying to highlight here is the several things that can sort of go wrong in the management of orbital fractures. The orbit or the facial skeleton is essentially a very complex structure with a lot of facial buttress systems present, which with the aim of protecting the soft tissue in situations of trauma. And then when you have a trauma, there is resultant fractures, which can be graded from simple to complex. So we're going to move on with the cases for today. We have 5 cases. This is the first one. So this is a young lady who had trauma, a road traffic accident, following which she underwent primary repair for the lacerations above the brow, on the forehead, and then oblique laceration cutting right across the brow. And that was what was treated about 3 months ago. And then she comes with this sort of disfiguring enophthalmos. As you can see, she has a floor and a medial wall fracture. The inferior rectus is seen close to the globe over here. So the indication for treatment was just pure enophthalmos. She did not have any other concerns. It was just this cosmetic concern of enophthalmos. She underwent repair with a 3D titanium plate, and this is the post-operative view where you actually see that the plate is in very good position along the coronal plane. It was in a good position along the axial plane and the sagittal plane as well, with the posterior end of the plate actually resting on the posterior ledge. But despite that, she has these enophthalmos which sort of kept bothering her. So if you look at her pre and post-operative pictures, there is a little improvement, but you still have this residual enophthalmos which you see very commonly following fracture repair. So now my questions here are, probably Samir, you can take this. When you have residual enophthalmos following fracture repair, simple floor, medial wall, what are your checkpoints? What are the things you go back and check for?
Yeah, so the important things which I like to check for a patient present with residual enophthalmos is there any entrapment of the soft tissues with the plates, with the mesh or implant what we have put up. Second thing is to look for the adequate correction, what always, or a migration or displacement of the implant. And third thing would be any soft tissue like a skin factor or a skin scar that is causing a tethering effect and causing a enophthalmos. These are the three things I would like to look for.
Right. Thank you, Samir. So Akshay, this one is for you now. If you see, you do a post-operative radiograph and you realize that the plate is malpositioned. By malposition, I mean that, say, the posterior end is not on the posterior ledge, and that is what is producing this relative enophthalmos. So what would be your strategy? What would you do now?
Akshay, yeah, I think it's, yeah. So a couple of things to see. First is to see how much is the functional residue. If there is if there is still motility issues, if there is diplopia in primary gaze or in down gaze, then I would think it makes things simpler, because then you obviously have a clear indication and motivation to offer surgery to the patient, because it's not purely cosmetic. The pitfall of offering surgery to patients who are not functionally affected but have enophthalmos because of a malaligned plate is that you can induce new post-operative strabismus and diplopia, which then is more troublesome to the surgeon than the patient. So these things are a little tricky. If the patient is not symptomatic in terms of functional diplopia, then I think I would be more inclined towards option number 4, that you've mentioned, either fat or filler, if it is amenable to that. But if it is too significant or too much of enophthalmos, then, and if the patient is really motivated, then with a very guarded counseling that there is a possibility of post-operative strabismus as well, I would be open to operating and realigning the fracture plate or putting the new fracture plate. Just if you could go to the coronal image of that, of this patient, yeah, I think the angle is good. The placement of the floor is good, but I suspect the vertical portion of the implant is probably a little bit into the ethmoids, which is, yeah, that could have been a little more vertical, as if you compare it to the ethmoids on the other side. So possibly that could account for the little bit of enophthalmos that she has, because the volume, the floor has been replaced, but that volume is being adjusted medially.
Right. Thank you, Akshay. So certain excellent pointers there when you have post-operative enophthalmos in a two-wall fracture, to go in, image the patient again, look at the radiology and see if your plate is in position. Very fine points that both Akshay and Samir brought out. Look at the vertical part of the 3D plate as well and see if it is in good alignment. Probably a bone scan would have done more justice than a soft tissue scan in this sort of a situation. And then if you have any soft tissue residue in terms of motility restriction that the plate is producing, you would sort of err on side of plate repositioning. But if you do not have such pointers, no motility restriction and diplopia, you might look at fat or filler correction for the enophthalmos. And even if it might be a sighted eye, though there aren't many reports on it, but there are people who actively perform fat or filler augmentation for that residual enophthalmos. Right. So we move on to case 2. So this is
can I add one point to this for
yes,
the previous?
go ahead.
Yeah. So in addition, in relation to the placement of an implant, it's very, very important that the posterior portion of the plate should actually be lifted to maintain the S-shaped configuration of the orbital floor. So that is more important. Sometimes what happens when you're dealing with a very large fracture, the posterior portion of the fracture, though you place an implant, the implant actually lies flat. So that needs to be put at an angulation so that it forms. And in that condition, a wedge-shaped implant actually becomes handy and is quite useful. So that needs to be taken care of. Then only we can.
So that's an excellent pointer where Samir says that along the sagittal plane from anterior to posterior, you give a curvature to the posterior end of the plate to lift it up. Samir, a couple of questions on that. So in this situation, 3 months post-trauma, would you have directly gone for a wedge implant, or would you still have opted for a 3D titanium? Wedge would only correct your floor and not the medial wall. So what would you do?
So I would have gone for a 3D implant. So what I would have done, what I've learned from Dr. Gautam is just to bend it manually. So whatever plate you have, you have to bend it when the posterior portion of the plate, just try to bend it a little bit so that it gives a posterior hump kind of thing, and that actually lifts up the eyeball and corrects the enophthalmos very much, very nicely. So I've seen him doing in a couple of cases where he just uses a 3D implant and he bends it manually at the posterior edge so that it gives a very nice lift.
Any cases of optic nerve oscillopsia you've noted with that, or you
no, I luckily have not noted any kind of disturbance like that.
Right. Okay. Thank you, Samir. So this is another gentleman who you see has a little bit of ptosis, has a little bit of enophthalmos on the right side as well, following trauma. And these are his scans. So you're seeing an obvious fracture of the zygoma there, medial wall, as well as the floor. And you see that the zygoma is significantly displaced if you take a look at this scan. So this is how he is. Again, one of the major concerns here is his enophthalmos. And we went ahead and performed a correction for him where the zygoma was again placed into position, the floor was corrected, the medial wall was corrected, and you still have residual enophthalmos. So now from a 2-wall, we've moved on to a 3-wall fracture. One point that I want to go back to the scan and mention is this the zygomatico-sphenoid suture. And in this 3D reconstruction, you can actually see that the fragment of zygoma is extorted and it has left back some amount of a gape here at the junction of the zygoma and the sphenoid. So that is my question now to the panel, that when you have this sort of a fracture with a 3-wall fracture, you assess him on post-op radiograph, everything looks normal, the orbital aperture looks normal, but you still have an annoying gape at the zygomatico-sphenoid. So the question here is, Shahid, if you are here, maybe you could take this up. Would you actually, while performing your open reduction internal fixation, dissect along the inner wall of the lateral wall, along the orbital side of the lateral wall, look at what has happened to your to your zygomatico-sphenoid suture, see whether it is aligned or not before you actually go ahead and perform your fixation at the frontozygomatic and sometimes at the body of the zygoma.
Yeah, Tajni, am I audible?
Yes, Shahid.
Yeah, so Tajni, these are those cases where an oculoplastic surgeon should always consult and take a help of a max fax, because these sort of a fracture, they need a 3-point fixation and a sublabial incision. The whole of the zygoma, it needs to be lifted up, and the point that you showed, that zygomatic or sphenoid suture, there a plate and screw needs to be fixed, and that area has to be that area. You have to tackle that area, you have to fix that area, otherwise the enophthalmos will not get corrected, and then you have to focus on the floor and the medial wall. So a 3-point fixation and the lifting of the whole of the zygoma by a sublabial incision, preferably by a max fax.
Right. So while that incision allows you to perform this 3-point fixation, Shahid, that I mentioned, the question was that on the lateral wall, do you perform dissection along the lateral wall and go back and check whether these two fragments are now in alignment?
No, actually dissecting there, Tajni, it doesn't makes much sense or doesn't give you much of an advantage. When you lift it from the oral side, the whole of the area, when you lift it and you look for the occlusion of the teeth, so that gives you a perfect idea whether this fragment has gone at its correct place or not. Obviously, the patient is under general anesthesia, and you cannot ask him to show you the chewing movement. So what you do, you look for the occlusion of the teeth on table and lift this area as much as possible. You cannot go and go and dissect in that area, in the area of sphenoid. That's a bit risky also, because you might be going close to the optic nerve in that area. So you just need to lift that area and fix this portion here.
Right. So some excellent pointers here on a 3-wall fracture, where Shahid told us that you need several incisions. You need to team up with a max fax person. You need to correct the frontozygomatic, the maxillary buttress, as well as along the floor, and perform a 3-point fixation, and make sure that your zygoma has lifted up and is now rotated in the correct direction in alignment with the rest of the orbital bones when you have such complex 3-wall fractures. Right. So we move on to yet another case where you see this young gentleman, again, post road traffic accident. And quite frequently, you see that, in our part of the world, that individual specialists sort of attend to the individual defects. Like you see a plating that has been done here at the frontozygomatic. This is exactly what I was trying to point out in the previous presentation, that this has been plated, but look at that gap between the frontozygomatic suture, the zygomatico-sphenoid suture here. And he also has these multiple depressed pieces of bone. So in this sort of a situation, what would be the ideal treatment option for this patient? The floor has not been addressed. So Saurabh, if you could come in here and tell us that when you have primarily repaired fracture but partly done, what would be your way of managing this particular patient? All right. So until Saurabh comes up, maybe Samir, if you could go ahead with this.
Yeah. This actually, first of all, the plates what have been put for this patient needs to be removed, and the entire fracture has to be redone once again. Now, for this, as I have already discussed, you have to maintain this facial buttresses. So you can always prefer coming it from outside in and from top bottom. But here what we require is, after you have done osteotomies to reduce all the fracture fragment to the normal anatomical position, a fixation at the frontozygomatic suture here, and then coming on, if there is a fracture of the zygomaxilla here, this needs to be fixed again, and the entire fragment has to be moved in. So if the entire fracture has to be moved in so that the rim is actually formed. After that, as I told you, the zygomatico-sphenoid suture line has a defect. So sometime in some of our cases, what we have done, we have just went inside, we have dissected, and we have seen if there is any impingement of the soft tissues along this line. Otherwise, in regular cases, we don't do that. If you find an extensive fracture, you can just go and find out any impingement of the soft tissues here. Once it is done, once this entire structure, like the frontozygomatic suture, the zygomatic maxillary, and the rim has been reconstructed, then only you put a implant onto the floor. So ideally in this condition, when you have fracture, I would prefer a large titanium mesh to cover up the entire defect. And then following, if you require additional correction, you can always take up a porous polyethylene or bone, whatever is required, as a add-on or an onlay kind of implant. Now for this kind of fracture, usually this will heal over a period of time unless it is causing any cosmetic or functional disturbance. I will not touch the frontal bone fractures here. So I will leave it as such, except for a few fat injections subcutaneously to smoothen out the scars over here.
Right. So, Samir, that was the next question. So this gentleman particularly was only worried about the depression here and was not really worried about the many other aspects. So, Akshay, if you were to sort of fill this depression, what would be your choice? Would you go ahead with a filler? Would you go ahead with fat? Do you look at bony integrity and dural exposure underneath? If any of these, then from where fat, if you could just highlight those points.
Yeah, so I think because there's also an adherent scar, I would first, it goes without saying that a CT scan with bony cuts is important to know the status of the inner table in terms of how much fracture healing has happened. Even though it may be malunited, if there is an intact bony structure as the outer table, and whether the inner table is intact, you mentioned rightly, if there is dural exposure. If none of those things are there, then you can see that there is a little adherence to that scar. So needling is an option where you can go and separate the subcutaneous dermis to the adherent structures below. You can use a wide bore needle like an 18 gauge or a 16 gauge, or even a thinner one, and create that area. Once you've created that subcutaneous pocket, then filler is always a good option. But remember, that's a dangerous area to fill because you have the supratrochlear and the supraorbital neurovascular bundles there. So whether it is fat or filler, you have to be very, very careful in your injection to make sure you don't have an intravascular filler injection and its associated complications if there is a retrograde flow. But both are good options. I would probably go on the side of filler. I'm more comfortable with that. Fat, you need to overfill and then allow it to get resorbed and stabilize. And that I think I'm not comfortable with. I'd rather have the patient come in periodically for multiple dermal fillers rather than one fat, which can be unpredictable at times.
Right.
Yeah. So yeah, Akshay, one more point in this condition, because anyway, we are going to repair the maxilla fracture also. So you can take a small amount of buccal fat and just underneath the skin, we can just put a chunk of buccal fat underneath the skin. That actually evades the risk of fat embolism or multiple injections. That is one way to go for this scar.
Yeah,
and also allows him some buccal fat removal, which makes him look good.
Excellent. So we have three or four more minutes. So this is case 4. Again, gentleman post-trauma. You see that depression on the forehead there and a little bit of ptosis. And his main worry was that his eye looks asymmetric. There is that ptosis. Now, unlike the previous one, which had a frontal fracture as well, you see this depressed frontal fracture, which is a little different in the sense that it is producing this impingement over the SR-LPS, which is probably the cause of ptosis. And that was my thought process. And I went ahead and I drilled that fragment of bone just to realize that there's no change in ptosis. So what would be your strategy for such patients? Would you do a sequential drilling of that impingement over the muscle and then see if any ptosis repair is required? Or would you leave that chunk of bone, do a little fat on the forehead to give it fullness, and just go ahead with your run-of-the-mill levator resection? Again, anyone who would like to... Yeah, Shahid.
Yeah, see, I think you did the correct thing for such. It's actually a blow-in kind of a fracture, and if a fracture, and it mostly happens with the roof. So all these fragments, like if they are accessible, they should be removed as much as possible, as you did it. And obviously the ptosis didn't resolve because the damage which had like happened to the LPS, maybe it had become permanent. So you give us we give us 6 months of a time for it to resolve both the myopathic and the neurogenic component. And if it doesn't resolve, depending upon the amount of LPS action, you can do a LPS surgery or a sling. Yeah.
Yeah, thank you. Thank you. So we move on to the last case for want of time. This is very interesting, and I want everyone to sort of give their inputs on this case. So this was a young guy post these kind of fractures that you see over here. I've put up the cuts for you, all the walls involved, and you have a frank ptosis, and the eye is partly in the maxillary sinus. Now, what will you do in this situation? Let me see if we have one more. Yes, a couple of other cuts of the fracture as well.
So this is a clear-cut case where you will need a multidisciplinary approach. There is a large fracture of the roof, and globe has half of the globe has sunk into the maxillary sinus. So you will need a help of a neurosurgeon and a max flex for sure. Yeah, and then later on, if you like the things which they have been repositioned, you can take up the patient for ptosis repair. That's all I can say.
Yeah, Shahid, thank you so much. For the want of time, I'm just going to reveal the suspense here. So this is the first case in my career I have seen where the fractured bone has actually gone inside the eyeball. That was
Yes.
I thought that was an artifact. So I was going to say that.
No, it is evident from the scan also, from the sagittal cuts.
So
Yeah.
this was, I never anticipated this and only realized it on the table when I started to prep the patient and started planning for the inferior transconjunctival incision. And it was an open globe on table, and you can imagine the nightmare that we were in. And he had very poor vision as such from traumatic optic neuropathy as well. But then this globe went into thysis bulbi. We had to perform a scleral tear repair after removing this piece of bone from the eye. And along with that, we also did the fracture repair. But just to say that many times you get carried away by so much that is visible on the scan that small pointers like these might go unnoticed. So just a word of caution for everybody out there dealing with fractures to look at the minutest of details. Every section is important. The sagittal cut here giving you clear-cut evidence that the fragment of bone is actually inside the eyeball. So thank you very much, everyone. We've had an illuminating session and we've had great attendance. Thank you to all the attendees who joined us second year in a row, and we hope to see you again next year. Thank you to all the panelists who took their time out and made fantastic presentations for this session. And Purnima, we are handing over to you before time.
Yeah, thank you so much. It was a indeed wonderful experience because you all actually, everything is sorted within time, and I'm very, very glad that I don't have to interrupt now and then. So thank you so much for, such a wonderful and a very informative session. And thank you once again to all the speakers, and I have to proceed for another session now.
Thank you.
Thank you, everyone. Bye-bye. And all the best to the next session. I already see Dr. Harshil here.